and we'll be recording it and will be published at CarolinaPublicPress.org. So if you want to go back and look at it again, or if you want to share it with your networks or people that you work with, please feel free to do that too. So thank you.
Thank you, Angie. Welcome to everybody this morning. We have a panel of folks who are going to talk about issues related to mental health policy, and I'd like to introduce them to you. Christina Carter, to the right here, is Chief Operating Officer of Smoky Mountain MCO, which is a regional agency that coordinates mental health care for 23 Western North Carolina counties. Sonya Greck, in the middle, is Senior Vice President for Behavioral Health. I'm going to probably miss some of these points. Social safety net, community benefits, project redesign at Mission Health. And as many of you know, Mission Health serves a number of our counties throughout the region here, including especially Buncombe County. Jack Register is the State Executive Director and is also a registered lobbyist for the National Alliance on Mental Illness, and he's based in Raleigh. Could each of you just take a second before we get into the questions to tell us briefly about your organization and how it relates to mental health policy? I'm going to start with Jack and go back down.
So, good morning, everybody. I actually drove in this morning. I was in Wilmington yesterday, so I've been on the road a lot. So I actually am conscious. So, NAMI is the National Alliance on Mental Illness. We are the nation's largest grassroots organization that represents consumers and families and those affected by mental illness. We actually have 30 statewide affiliates. So there are several affiliates out here in the Western region. I am the State Executive Director, so my office is in Raleigh, and my responsibility is to be the sort of figurehead for us in terms of where we are in the state. I'm the one who sat on the governor's task force. I'm the one who's in the General Assembly a lot, so I'm sort of the voice for us in terms of big picture public policy issues. I come to NAMI as a family member. I also am a consumer myself, and I'm also a clinician. And so I wear lots of different hats in order to kind of talk about all the different experiences that those who are affected by mental illness in North Carolina bring to the table. So part of our job at NAMI is to tell a story. That's the one thing that we can do that nobody else can, is to talk about what it really means to live with mental illness in the day and age of North Carolina and all the system reforms that we go through. So thank you for inviting me.
Good morning. It's great to be here, and these are the kind of conversations that we need to be having. I'm Sonya Greck, and
where we are today, where we have come from, where we are today, and where we are going. A lot like what Sonya said, I think all of us are showing up trying to be the leaders that the consumers and families and people who are challenged with these disabilities need for us to be. This is a very trying time in the system, and I believe Smoky comes forward as we are managing the system. You hopefully have seen, if not, we'd love to educate you about our community reinvestment plans with the facility-based crisis and many other things that we're doing for the chronic mental health and IDD issues we have in the system today. One thing that I think is a very unique signature for Smoky that is different than the other managed care organizations is that with our board and our leadership, we have made a very local commitment. We have staff who live and work in every single one of the 23 counties so that there is a local presence, which we find that is very, very helpful to us to have a very local touch, to stay very locally connected, and then how that information feeds up into the organization so that we can manage the 23 counties appropriately and make the right priorities and decisions for all 23 counties. So again, thank you so much for inviting me, and it's a pleasure.
And Frank, I'd like to add one thing. We do something in our community all throughout Western North Carolina. We're required to do a community health needs assessment. We do this collectively with the health departments. So both hospitals and health departments are obligated to ask the community what are the needs and then put together a plan collectively on how we're going to address those needs. And we do that through a third party where we all come together. We just finished a cycle of that, so we're planning for the next 3 years, and that's where, again, a lot of the work that we've done has happened. So it's important, as you talk about, you survey people, there is a public document that is available that you can look at. It is by every county in Western North Carolina so that we can look at the regional attributes as well as our local attributes and what the needs are. And again, there's a lot of collective partnerships in how we address this. And this really is the guiding principles for us. And not only do we ask the community, we ask the community agencies so we could verify what were the needs. And again, mental health, substance abuse, to the top of our region. So it just verifies what you're saying as well.
I'd like to also add one more quick thing about NAMI structure. Majority of our affiliates, I'm sorry about that, that's part of the thing about being leaders, is that we're always trying to remember everything we want to communicate in these kind of settings. The majority of our affiliates around the state are completely volunteer. So we do have an Asheville affiliate, we do have an affiliate in other parts of Western North Carolina. So if you interact with NAMI, you'll interact with those affiliate folks. We at the state office are the state staff. And so a lot of times folks may interact with us through our affiliates up to the folks at the state. So that's one of the reasons why some people might know my name but not necessarily know where I come from, because I'm all over the place trying to be the thread, as it were, that connects all of our affiliates back to our purpose.
Thank you guys very much. Some of you may have seen an article that appeared on Carolina Public Press last week called Navigating the Cyclone. And this article looked at the issue of how consolidation of mental health and reforms in mental health services in North Carolina over the last 15 years have affected the clarity, the access, and the accountability of care, both in terms of the quality of the care and the efficiency of providing it. This was an attempt to ask a lot of questions. It didn't necessarily have all the answers, because part of the point was that some of these answers are a bit elusive. But I want to allude to something that Christina mentioned in talking about the history in the recent years in North Carolina and thinking about this issue. The system of connecting communities to mental health services has gone through really a substantial shift in the last 15 years, beginning in 2001 with major legislative reforms. And it's important. I saw one comment on social media that was responding to that article and said, well, how dare a certain party do this? And it's like, actually both parties have done it, so it's not a partisan issue. And you can quibble over whose policies have been worse, but anyway, it's been a complicated system under both parties controlling the state. But in thinking about what's happened over that long period of time, that in the way of a short period of time for such drastic change, and change that's happened in waves, what do you see as the important points of progress? And then what are some areas where this wave of changes, as we've had multiple rounds of consolidation, where there have been some undesirable results? And I'll start with Christina on that.
Okay, thank you. Well, the first place I'll start is, first of all, to just recognize
NAMI's mission is to make sure that folks are served. Our colleagues in the hospital system and our colleagues from the LME MCOs do the best that they can, in my opinion, because this is really complex. It's like trying to live in a tsunami while you're blindfolded. We, as the folks who live through this, hold them accountable for things that they can't always be held accountable for. There are a lot of things that we can hold them accountable for, and believe me, Christina and I have known each other long enough, argued with each other long enough, and still smile at our friends today, because that's how we actually create change. Because we have to take the conversations collectively to the folks who actually create the policy changes. We must align funding with our policy priorities in the face, because there are a lot of folks who aren't here anymore because our system was not able to respond to them. And that's not a North Carolina problem, that's a national problem. We've not done and lived up to, as a country, the social contract of caring for the mentally ill.
Well, you, Jack, addressed something that I want to ask about more directly, and that is accountability as a result of the consolidation. And just so everybody understands what we're talking about, at one point, help me out if I'm wrong on these steps, but I believe there were about being able to gauge the outcomes for both quality of mental health coverage as a result of those consolidations, and particularly the repetitive nature of the consolidations, and then whether that has taken a back seat in cost cutting.
So that is actually a really great way of framing it. What we would say at NAMI is that our system has transformed and that our crisis service array is where we have focused. Because it's really interesting and easy for a lot of folks to focus on the psychiatric crisis right now. We talk about mental illness being a lifelong issue like diabetes, because serious mental illness is not something that goes away once you achieve medication. We know by statistics that it can take up to 10 years to find the right combination of meds for somebody with a serious mental illness like bipolar disorder or schizophrenia. The concern is that our service array is not necessarily always designed from Murphy to Manio to serve folks in that long-term capacity. Because we have hospitals, yes, for crisis situations. We have service array that's available, ACT teams and so on. We don't have case management consistently because there's not a funding source, right? You can't really say case management in Medicaid without folks kind of going, well, the concern is that we have to start thinking about serious mental illness being something that is lifelong, that we're talking about folks having the right to live in the community and not be put into a group home or a facility unless that's what they actually need. But that means there has to be community services consistently across the state. That's part of what reform has offered us in the consolidations is more innovation. We would say that our friends at Smoky actually have done a really great job trying to be innovative in local communities around how do we build what we can given the resources that we have. Our concern at NAMI is that we're really good
that there are absolutely, the only way to solve those local rural problems is to sit in the middle of those communities and figure it out. I would love to think before any.
All of the team is involved, because we know that a lot of times the primary care doc is the one who might see the adolescent who's starting to have the beginning symptoms of schizophrenia first, or the beginning bipolar episode. So we are starting to find the idea of this integration, and that's really important, because the sooner we intervene with folks, the more we can move people to an idea of functionalized recovery. Because again, mental illness doesn't live, so they can own their illness to then be able to create a different life for themselves.
Thank you. I want to ask one more question from my previous list of questions, and then I'm going to open this up to the audience for some questions. Angie referred earlier to a report that we had no ability to step in, and that they continue to assign patients to this facility despite the fact that there was, at least by community legal standards, some evidence of pretty strong problems with the facility. A schizophrenic patient who didn't get his medication, he had to have a monthly injection, and they forgot on a particular month. A patient who had very serious dietary issues, and they just went off the script and gave them whatever they wanted. And very disgusting conditions that were described in the bathrooms and the kitchen of the facility. Those types of things, and there were other violations there as well. Despite these, the regulatory system wasn't able to do much. So I guess the question this leads to is there a problem with our regulatory system with regard to particularly agencies like adult care homes serving a mentally ill community? I'll start with Jack on this.
Yeah, so I'll just say that we can't necessarily do anything about it, but it doesn't mean that the community cannot be involved. Part of our job at NAMI is to gather the stories and take those stories to places. As soon as this became apparent to us, we were meeting with legislators from that region. We were meeting with folks from the departments. We were actually having conversations with folks demanding something be different. It's not okay at all with us. And remember, sometimes NAMI families have a tendency of speaking to folks with pretty red faces. I'm pretty good at that when necessary. But we try really hard to come at things from a collaborative, let's create change together, but we're not going to be quiet about this. So I wanted to be really clear that this did not happen without folks noticing this across the state. We have a helpline that is statewide that we tell folks on a regular basis, we're not okay with this, believe me.
Amy, let me just say, I just really appreciate so much your story, and thank you so much. I can't imagine what it would be like to stand up and say, so thank you very much.
Thank you. I appreciate the discussion. First, I just wanted to I appreciate that you all have come and what you're talking about. You're mental health care people. I come at this and I have been shocked by the system and do it repeatedly. So there is no funding and to get into communities. It's not something where they can